Thank you for joining us today. There's a lot of preparation that goes into these webinars, and so it's really great for us as a team to see the volume of people who can make the time to come along and hear more about the progress that's made in relation to the MAT standards implementation. So before we get kicked off, let me just do some introductions and some housekeeping. We do ask that when you're joining us today that you mute your microphone and switch off your video. It does help the call quality. We will be using our chat function today, and use that to post your questions or any reflections. And it's also a really good way for you to see what your peer group are saying and the conversation that is happening, and make some connections. After each of our speakers today, we're hoping to pick up any questions that are posed within the chat function, so please use that as best you can. If we run out of time, then we would probably pull that all together in a sort of Q&A and circulate it after the event, and allow presenters the opportunity to contribute to each of the kind of questions. If for any reason you experience technical difficulties, the email address that you should use to report that is his.mat@nhs.scot, and you'll see I've put it in the chat with somebody who's struggling with their audio. Before we get into the purpose of the event, I just wanted to quickly talk about the emotional impact of talking about drugs and alcohol, and some of the harms that can be created as a result of that. Some people might find that triggering, and what we ask is that you look after yourselves. If you feel that the subject area is too much, or you feel that actually there's something being said that you disagree with, we ask that you just feel free to leave and let us know about that situation or your experience of that. We absolutely recognise that when you're working in complexity and you're working alongside people who are using drugs and alcohol and their loved ones, that it's a really emotive subject area. So we want everybody to be aware that the chat is a public forum. It's, you know, it's open to everybody who follows the link. So don't put anything private or confidential in that, unless you feel that that's appropriate to share. But we would ask that you just keep that in the recognition that it's a public forum and lots of people have access to it. If you would like to have any specific conversations with me or the team that do this work, please email us privately and we'll pick that up. You can get that at his.mat@nhs.scot if you don't feel comfortable using the chat box and you've got any reflections. So before we get started, I wanted to just give you a little bit of context. So the last webinar that we had an event around, we talked about the importance of joint working and some of the issues that can come out of that in terms of data sharing or coordinating care across multiple different systems, and the difference between working in the public sector versus the third sector. So today, when we asked for feedback at the last webinar, we heard quite strongly that there was this real appetite to discuss the importance of data sharing and joint working. So we're hoping today that we've given you a little bit of that in microcosm. So over the course of the morning, you're going to hear from a couple of really interesting people. So first of all, we've got Stephanie Stewart. Stephanie is our Senior Improvement Advisor for the MAT Standards Programme within Healthcare Improvement Scotland, and she's got operational responsibility for the delivery of the webinars alongside all of our other digital kind of content. So she'll give you a little bit of an update on how that programme's progressing, some of the key things that we've been able to do and achieve. And I think she'll give you a little bit of a reflection about the importance of collaboration and why we can only do this with the contribution of colleagues who are delivering that care. And then I think she will give you a little bit of an opportunity to kind of understand how you can connect your work and the opportunities that might exist for you to do that. We're going to pass then on to John Thayers, who's the Research and Safety Manager over at Mid and East Lothian Drug Service, and give you a little bit more insight in terms of the contact service with two of his colleagues, Bob McConnell and Laura Fearn. So it'll be interesting to hear from them how they've adapted to the world that we now exist in post-pandemic and the changes that's been made as a result of that. I'm hoping to give you a break around about 10 to 12, depending on time. If any of their speakers overrun, we'll possibly have to shorten that, but we'll see how we go. As I had said to you previously, during the presentations from our speakers, please use the chat function. Please use it as an opportunity to pose any reflections or thoughts. If you're happy for us to open your microphone and your camera and ask any questions that you maybe have, please let me know that. If not, I'm more than happy to present the questions to the speakers. So after our break, round about noon, all being well, we'll get Elise McConnell from the Glasgow City Mission, and she's going to give us a little bit of information and her insights from the Glasgow City Mission on the challenge of information sharing and recognising the connection between complex needs and homelessness and the importance of access and availability of services for the homeless population. So hopefully that covers quite a lot and is a useful opportunity for you to hear from colleagues who are battling probably the very similar issues to yourself in the delivery of treatment and recovery services. And we're hoping that after today we'll collate your thoughts and feedback and use it to help design our next session. So before and without any further ado, I'm going to pass you over to Stephanie Stewart. So as I'd said, Stephanie Stewart is our Senior Improvement Advisor for the MAT Standards Programme within Healthcare Improvement Scotland. And our primary role is to support the MIST team, who I'm sure you all know, in making sure that we give them a learning space and a learning network to share practice, to engage with the people who are delivering MAT standards and to learn from each other. As I said, we'll use the chat to pick up any questions, and hopefully Steph will be able to give you an inside track on our programme, how we're progressing and some of our next steps. So Stephanie, I'll pass over to you.
Thank you, Ruth. Kyle, you could just pop in the next slide. That's fab, thank you. So as Ruth says, I'm Stephanie Stewart and I'm the Senior Improvement Advisor working within MAT Standards. So yeah, next slide is fine, Kyle, thank you. So just thought, recently we've appointed our Improvement Advisor into post within HIS, and I just wanted to kind of take this opportunity to really formally introduce him and also to put some faces to the names of the others within the MAT team, some of which you're probably more than likely will know or be aware of, but it's just always nice to get some faces to those names. So as I've said, I'm Stephanie Stewart and I'm the Senior Improvement Advisor working within HIS on the MAT standards. And my role really is, as Ruth says, is to kind of drive and lead the operational delivery of the programme deliverables, which, as I say, I'll go into more detail as the slides progress. Working alongside me is Stevie Wishart, who's the Improvement Advisor, and some of you may have already met him during his induction with HIS, or possibly even within his previous role with Shelter Scotland. He will become a more familiar face to you all as he seeks to understand the current activities and plans for those next steps. Another probably familiar face if you've been around MAT for a wee while is Adrian McKenzie, who's our pharmacy clinical lead for MAT Standards. And he's really here to kind of provide that clinical expertise to the programme, along with leading on a piece of work around community pharmacy, which again, I'll go into a bit more detail later on. Kyle Taylor is our project officer. Among many other things, he basically ensures that we're all organised, keeps us on track with actions, and we're able to report on our progress. And it's really integral to the successful delivery of these webinars. Like I say, without him, who knows what would end up happening. Leanne Clark is with us as programme manager, and she also has a role support in the residential rehab programme within HIS. So it's good for that kind of overview of the two programmes. She ensures that we take a programme management approach to our work and really supports Kyle in applying this to all of our activities. And Sophia Madden is our knowledge and information skills specialist and basically supports us in finding, capturing, analysing and sharing knowledge and information to inform our activities. And also ensure that when we are communicating outputs, that these are sort of easily understood and accessible and also appropriate for who we're actually trying to reach. And of course, as we all know, our chair today and portfolio lead is Ruth Robin, a well-known face now at these sessions and the strategic leader of both the MAT programme and also the residential rehab. Next slide, please. So, in the interest of kind of collaboration, I just wanted to kind of take the opportunity to share with you, what the agreed deliverables are for the MAT programme within HIS. And these are commissioned by Scottish Government as we're here to basically provide the improvement support for MAT standards implementation. And we're, as Ruth says, working alongside Public Health Scotland's MIST team. So I'll go into more detail about these as I move through the slides. But in brief, the key deliverables are the development and delivery of the MAT learning system, which includes a series of webinars, and impacts and implications assessment on pharmacy services with a specific focus on community pharmacy, the production and publication of a suitability spread report, and the design of a national improvement programme for MAT standards implementation. Understandably, the deliverables are quite broad, and what's really important to me and the team within HIS as well is that to always remember that it can be really challenging at times to keep going, to know where you're going and also how to get there. And none of this can be done in isolation. So hopefully, as I'm progressing through this, and in general, with the session today, you can see that kind of recurring theme about collaboration and working together, basically. Next slide, please. So I'm not going to tell you who I am in this picture. I'll leave that up to you, although I'm pretty sure my husband would liken me to Hulk on a regular basis. But in the case of the programme and the deliverables that we're trying to achieve with this programme, this is where I really start thinking about collaboration and teamwork. And as I say, this isn't only with the direct team within HIS, it's really about that value of connecting with others, no matter who they are and where they work. For me, it's really important to find your allies, and form basically a big super team. We could call ourselves the Avengers if we want, or we can come up with an even flashier name. So, and basically, in the interest of collaboration, it's really about all working towards that same goals. And that's when real change can happen, if we know that that's the vision going forward and this is what we're trying to achieve. I've been involved in sort of numerous projects and programmes over the years, and what I've always found most useful and kind of paved the way for the biggest success was taking some time to work out, who did I need to connect with and how was I best to do that. Once I kind of identified that, then it was about sort of providing that space and opportunities to hear about challenges and potential solutions. And that really done wonders for the programmes that I was working on and how they then progressed. Ultimately, we're all here for the same reason. We want to help and we care. It's as simple as that. And for me, I'm kind of hopeful this resonates with yourselves. And I like that, I'm here to really contribute to service improvement, improve the experiences of people accessing those services, reduce harm, and ultimately help the people that need our help. Next slide, please. So how are we within HIS sort of doing this at the moment? So as I said, one of our key deliverables is around the learning system. And the aim of this is to really provide that space and opportunity to hear about challenges, potential solutions, and make connections. This is now our 4th webinar, and these have provided opportunities for you to hear from others about what's working well and also what are the challenges. It also has allowed us to hear about what your challenges are and how we could potentially help along the way with getting to know the services that are involved in the delivery of MAT standards, as we really do recognise it is much wider than just health and care services. Over the coming months, we're going to continue to sort of develop the learning system, with our next webinar planned for the 31st of October. Halloween outfits are optional, of course. We will also be taking time over the winter months to consider other ways in which we can engage with each other to share insights and challenges and encourage connections. And part of that is looking at sort of podcasts, blogs, and also the development of our online resource library. We're working with the MIS team in relation to that, as they do have obviously examples of good practice through their engagement with local teams. If there's things that you would like to share and would like to see to support the learning system, then please do pop them in the chat or drop myself or the team an email. Next slide, please. As I said, also ongoing is our community pharmacy insights piece of work, and this is led by Adrian. The images of this will be disseminated through the publication of a report, an online webinar as well, to kind of get that narrative out there as to what we've learned. The findings will inform sort of recommendations to Scottish Government in relation to what the service specification for community pharmacies would look like to support delivery of the standards. We recognise that there are wider, pharmacy services, like that within acute prisons and GP practices. However, for the purpose of this, we're really focused on community pharmacies, as they are in the heart of communities and have contact with the whole community, including friends and families of those that are requiring support and access and services. Another point in relation to sort of that community pharmacy location is that there is twice as many pharmacies in the areas with highest deprivation compared to areas of lowest deprivation. So they very much are in the area of those people that we're trying to connect with. The work is made up of 4 key strands. The literature review is near completion, and it's looking at understanding, what is the national and international evidence about the role of community pharmacy in delivering MAT standards. As I said, it's near completion and it will form kind of part of our final report, but it's also informed our other activities that we've been doing along the way. We're preparing to go out to the community pharmacy leads at the health board level to get an understanding of what services are currently being provided by community pharmacy that supports the delivery of the standards. I've also been interviewing a number of stakeholders to understand what does good look like from a service perspective. To date, we've completed 18 interviews, and these have included representations across pharmacy at local and national level, representation from academia, third sector, health boards, and national groups as well. And then the sort of final piece of the puzzle, so to speak, around this, and as I say, we're in the initial planning stages for this, is to engage with those with lived and living experience. So we've kind of got, from the stakeholder interviews, what it looks, what good looks like from a service perspective, but actually what does good look like from a user perspective. So, through this work so far, kind of for me, what I'm really hearing, from the system in relation to, what is needed about community pharmacy in delivering the MAT standards, is there's a need for that single service specification for all community pharmacies across Scotland to ensure that consistency of service and also reduce inequalities. We're also hearing about the important role of community pharmacy. No one's kind of dissuading that to say, they're not to be involved. They're very much recognising how important they are in the delivery of the standards and that they need to be seen as key partners. And also that there's a need for that understanding of everyone's roles and responsibilities. And lastly, there's the ongoing recognition that they are part of the community and are well placed to provide a number of things, including that support, advice and signposting. Next slide, please. So we will keep you up to date regarding the community pharmacy work that's ongoing. And if there's anything you would like to share relating to this, please do get in touch. We'd also encourage you that if you don't already do this, involve your pharmacy colleagues in discussions around how services can meet the needs of the local population around substance use. Many boards have a specialist pharmacist of substance use, or SPISMs, who would be the first port of call, and they can link you in with the lead for community pharmacy services to support you in those discussions. There's also the local pharmacy contractors committee, which you can get in contact with either through your local board pharmacy contacts, or Community Pharmacy Scotland can also put you in touch with your local committee. Next slide, please. So as I've said, what we're also really keen to hear about is those areas of good practice. And with CV now in post, we'll be engaging with ADPs and partner organisations and providers to understand, what is really working well, and could this potentially be spread on a more national basis to sort of form that production of a suitability spread report. But we're also very recognising the differences within each locality. It's not necessarily a one-size-fits-all. With this in mind, it's going to be about understanding, what are the key principles, the systems, the processes that are needed, and how can these be adapted to work at a local level. Again, we're really keen to hear from yourselves about anything happening in your area that you may feel would be useful to hear. So, again, pop your details in the chat, reach out to us via email, come in at the end of this presentation, whatever you're most comfortable with. Next slide, please. As with the community pharmacy work, we'll also be looking from that wider programme perspective to engage with those with lived and living experience, their friends and their families as well. To fully understand how what looks good for them, good looks like for them, and not just in the context of community pharmacy, because there's, as I say, that's just sort of also one element of those MAT standards. As we develop recommendations and suggestions as well for system change and improvements, we really want to ensure as well that we're connecting with them, to really sense check that the track we're on and the suggestions that we're making isn't going to have a detrimental impact to them. And like that, to really involve them into informing our work and informing our recommendations going forward. For me, it's really important to hear from those that are using and working in the services and truly listening to what they have to say. We may feel from a system point of view that things are working, everything's fine. However, to really fully understand that broad picture and around, yes, it's maybe working for us, but is it working for them? We need to go out and ask them and hear from them in relation to that. Next slide, please. So as I said, in the interest of collaboration, and as you'll have likely picked up as I've been talking, we are really keen to hear from you to understand, who are the key partners and organisations that you're working with, and ensure that we are connected in with them also, and have a national sort of understanding and overview of everyone that is working to support people around MAT. And also we need to hear more about what's happening in the services, particularly, what's going well. If you've got a story to tell, as I say, please get in touch, so as we can look at how best to get that narrative out there to others. And it's like that, it isn't necessarily through the webinars, it could be through case studies, podcasts, blogs and whatever. So we've got lots of ways to try and get in touch with folk and get that story out. Next slide, please. So thank you for listening, and these are the contact details for myself and Stevie and the MAT team. If you have any questions, pop your hand up or pop them in the chat. Thank you.
Thank you very much, Steph. I know it's a lot to cover within the time that you had, so thank you very much. One of the questions that's in the chat, and I'm keen to understand a little bit more and share more, and I know that it's emergent thinking, but it might be interesting for colleagues to be aware, is how are we and how will we engage with lived and living experience? Do you want to give us a wee bit more detail about that?
Yeah, I can do. So at the moment, yeah, we're very much looking at like that, what is the best way of kind of engaging with people to get that narrative and get that story. And it is something, as I say, that Stevie's sort of leading on around this. And it's likelihood will be that we do have obviously public involvement officers on the residential rehab team. We've got a community engagement team as well within his that will be seeking advice and support from. And like that, we'll be looking at, what third sector organisations and advocacy services are out there that we could potentially use to help kind of open that narrative. And I see Stevie's got his hand up. I don't know if he still does actually.
David, do you want to come in and just add to that contribution?
Aye, so I've already just started mapping out just to complement the work that Adrian's already done in relation to community pharmacy and ADP leads, etc., that we've already engaged with in regards to that work, and started mapping out the SIMD and the drug death stats and the initial data that Public Health Scotland took last April in relation to ADP feedback for MAT implementation, and use that as a kind of model to map out areas of interest to see, and with that then corresponded that with the Cora Foundation funding and the Drug Death Task Force money. And it's given us a list of organisations within each of the areas that we started making contact. And we're going to pick up kind of initial discussions with kind of grassroots organisations upwards, including family members, etc., that have shown up in that. And then with that information, with the information we've got, we'll build a kind of a more comprehensive kind of list of engagement work that we're going to do with these groups, and then start making contact in person, hopefully, and start coming to these areas, maybe 6 or 7 areas, just to kind of map out what's good and what's bad, and well, not bad, what needs improvement, and hopefully mirror that going forward. But happy to engage with anybody that's got a better idea of what's to come along the journey with that as well. See how that goes.
Thanks, Stevie. I think it's important for us to share with colleagues that we've took a human rights-based approach to engagement planning. So we've very much tried to understand the complexity of what's happening for people who are using services and how might we hear from those voices. And so we've intentionally reached out to the Cora Foundation to understand all of the kind of opportunities for providers to engage with. Within the residential rehab work that I'm connected to, there's a sort of infrastructure around providers, and we realise that not all providers engage with that, so we need to kind of be quite intentional in making sure that we get quite a diverse perspective in our work. So we are trying to get that right, and if there's anything that people feel that we should be doing more of whilst we're in this design phase, it'd be great to hear from you. Alison, I see you getting a hand up. Do you want to come in?
Sure, and I see that Cassandra's already put into the chat there about the team that we have in Scottish Government on participation in human rights, which I think would recommend that you link with them. I would just say that there's been a good deal of work at them over the last kind of year or so, reaching out through various different networks. on engaging with people with lived and living experience, and particularly with living experience. And I would just say, if you could tap into some of that, because what I fear is that you know, some of our drug using population will roll their eyes and say, goodness sake, you know, like we've been through all of this, you know, like with you know, X other organisations. So I would you know, maybe reach out to Cassandra, who's on the call just now, and others, and say, you know, what's out there already. As I say, there's very active living experience groups.
Yeah, I absolutely, Alison, and I think that's the trick, isn't it? Not to duplicate anything or repeatedly ask the same questions of a group of people who are probably exhausted by all of it, because they're still actively seeking treatment and recovery. So I absolutely take your point, and it's well made. I know Cassandra, so I sit on the National Collaborative, and so I'm aware of some of the work around that, and we are absolutely trying to make sure that we lean into the existing infrastructure, but also recognise that not all organisations and grassroots community-led systems engage with that infrastructure, and how do we make sure and sense check some of that. So I totally take your point, and it's well made.
So sorry, so living the Scottish Drugs Forum also have living experience groups, and they have a sort of an external network from there. So I would just make sure that they're also linked. Yeah, absolutely. It feels like we're all connecting in lots of different places, and some of our colleagues in evidence and evaluation have been doing social network analysis, and that has quite quickly shown how much connection there is across drug and alcohol systems. So absolutely, Alison, you're bang on. We'll absolutely make sure that we connect into the existing relationships as well, as much as anything else. Okay, thank you so much, Steph, for that. I'm going to pass us over now to John. John, if you want to put your camera on. Thank you very much, John. I'll pass to you and you can do your introductions. Thank you very much.
Ruth, thanks very much for the introduction, and also thanks for the invitation to for us to come along today and share with you some work we've been doing in the MELDAP area around improving access to services. And I'm joined today, and they're going to do all the hard work. That's a great thing, I have to say, by Laura, and a special thanks to Laura, because actually she's given up a Friday to join us in the webinar, and Bob from MELD. And MELD stands for Mid and East Lothian Drugs, and they're our main third sector partner, and also the service that's been responsible for actually taking forward the contact service initiative. They provide the staffing for it, the support for it, and through early discussions, it was some of their ideas that emerged about how we could change things. And I'll just set the scene very briefly about why we change things. Next slide, please. Actually, looking back, it's now about 10 years ago since we conducted a Kaizen event across Mid and East. And the Kaizen event brings people together from all levels of the health service, in terms of third sector partners, statutory services, people working at FACE, strategic managers. And one of the recommendations that came out from the Kaizen event was that we introduced things called gateways, and this was the gateways to recoveries. And these were set at locations across the MELDAP area that operated on a Monday, Tuesday, Thursday and Friday, and people could drop in and actually be seen, details were taken, and then people would be referred on to treatment services. The MELDAP area is quite geographically wide, although the population is not huge. So there was always the trouble about how you access that, and that was always going to be a challenge. The other challenge was, and we probably, in reflection, forget that if you're seeking treatment, making that first step can be a huge step, actually going through a door, meeting people face to face that you don't know the circumstances. And so what we felt was, as things moved on, it was probably time to take a fresh look at it. So you can see some of the challenges there: limited opening times, and people walking through the door, what they thought was available actually wasn't available, or they didn't qualify it for it. And there was a sense that sometimes this wasn't the most productive use of time. Next slide, please. So it was a good first step, I have to say, in terms of moving on from the recommendations of the Kaizen. It was certainly an improvement in terms of what we had, but it did come at a cost. And these are some of the issues that were certainly identified. It was labour intensive. We needed 2 members of staff each day at the gateway. It was probably not really effective at engaging people in recovery. Sometimes it could be extremely busy, as we've seen, but actually many days it was often very poorly attended. So what we actually had was we had 2 members of staff, one from NHS treatment services, one from MELD, who could often sit for long hours at these locations and see 1, 2, and sometimes actually nobody. So that investment of time and expertise, we felt, could we do things differently? And in a way, and hopefully the next slide will touch on this. Next slide, please. Along came COVID in some respect, and that also helped drive things forward. But there were other factors around. It wasn't just COVID. We were certainly aware that many people's perception of the gate was it was very much opiate. We were aware that the changing pattern of drug use around stimulants and other drugs wasn't really being captured through the gateways. And so given that the gateways were 10 years old, labour intensive, sometimes getting very poor returns, we really felt that it was actually time to take a fresh look at actually how we delivered access into services. And basically, we, through MELD, applied for funding from CORA. We got the funding. We basically set it up as a pilot service. We evaluated at the end of a year. And in fact, we were so impressed by the pilot work that we extended it across the whole of the MELDAP area. And then we also continued to provide the funding for it. It is still a young service. It's really only just over a year old. There's things that we are very pleased with in terms of what has been delivered. There's things we would change. So, for example, one of the things, and Bob and Laura will speak a wee bit more about in detail about that, is that we have extended the hours of the contact service to cover weekends, because we know from what people tell us there is a demand for some form of support and access evenings, weekends, etc. So things we think are going well. We think, as I say, there's probably room for improvement, but specifically how it operates and some of the challenges, Bob and Laura will talk us through. So over to Bob and Laura.
Okay, thank you, John. Good morning, everyone. Just to say that I'll keep on this slide just now and give you the overview from the operating service here. With the onset of COVID and all the associated changes, restrictions and safety procedures affecting practice, it was impossible for Midlothian and East Lothian substance use services and MELD to continue operating in the established manner of service user engagement. As you see from this, the approximate attendance at any gateway recovery clinics during the years previous to COVID was approximately 300 to 350 people. The limited time available for engagement in Midlothian was 8 hours, 5 hours in Dalkeith, 3 in Pennycook, and in East Lothian also for 8 hours, 3 hours in Haddington and 5 hours in Musselburgh. So there were restrictions to the ability to engage. If we just go on to reaction to COVID-2 slide, please. I think it's further up. I'll just read
the COVID one. Sorry.
Okay, when the restrictions were announced as a reaction to the COVID pandemic, the way services operated changed overnight, as did the ability for the public to engage in any form of treatment offered by the services. At MELD, we were tasked with keeping the doorway of treatment open, and it was quickly decided, mainly due to circumstances, that we'd initially set up a contact number for the public from both Midlothian and East Lothian to continue to access services with a view to engaging in treatment. The initial premise at the time, if we can all remember back, was that the service, etc., would operate in a different manner for approximately 3 months, with the initial expectation being around 6 to 8 weeks. Looking back, that seemed doable at the time, but with the extended period COVID actually affected us, we had to again look at how we were going to do it. So if I can have the next slide, please. The MELD Contact Service. So the MELD Contact Service started as a one-year pilot initiative, and if I look back, I've got the documentation there that promoted the service initially. So I'll just read verbatim from what I have here. The MELD Contact Service is a one-year pilot initiative funded by CORA and MELDAP. It is focused on offering information to the public regarding substance use inquiries and easy access to substance use services in Midlothian and East Lothian where appropriate. Clients or patients looking to engage in substance use support services or looking for information regarding substance use are encouraged to call this contact service helpline and is engaged in a confidential, trauma-informed, person-centred conversation focused on addressing their concerns and needs. I think that's the basis of the whole contact service, is that there's a degree of anonymity here that allows people to talk openly without things being recorded, just deal with the issue before they are then directed to the most appropriate service or combination of services to help them cope. So it's basically their decision about what the first step's going to be, knowing within services that we have a fluid attitude to where people need to be at any one time, and they can be transferred seamlessly from one service to another or combination of services. So the combination of services available to the public at that time would include MELD, Midlothian Substance Use Service, East Lothian Substance Use Service, ELCA, Peer Support Services, Family Support Services, Smart Groups, AA, NA, CA Fellowships. If requiring engagement with MELD or substance use services, a triage appointment would be agreed at the time of first contact or actually completed at the time of first contact, where information would be taken and referral made to the most appropriate service or combination of services. People were also encouraged to call the contact service directly, therefore they could have their needs met, their questions answered, and have a degree of autonomy in what the next step would be for them to engage in services. Can we move on to the benefits to the public slide, please? So basically, from the information gathered for what we had at the time, the public benefited from gaining access to treatment at any time of the day or night at a single access point to service most suited to their needs at the time they call. The service does not operate 24 hours, but access is available 24 hours with a call returned or text messages returned on the next day, which is now 7 days per week with the weekend cover we have had the extension funding for. So at that point, again, they're immediately engaged in a conversation about their particular needs, offered information and guidance as to what service is most appropriate for them at the time of the call. In the case of same-day prescribing, we are able to book an appointment directly into nurses' diaries and confirm that appointment time immediately. If requiring transport, we can also arrange and let other services know that taxis or some kind of form of transport is required. So it can be done through peer support, public transport if necessary, but just give people the ability to come to appointment at the right time. So if we want to go back to the initial slides round about the engagement, I think that's from slide number, yeah, there we go. So the total number for the contact service Midlothian in the fiscal year 22, if you look at Q1, that's 180. That's reflected this year. We have a total inquiry number of 226, which is a 25% increase on the first year. So it's not slowing down. Actually, it's increasing at a pace. The inquiries now can be different. The reflection on engagement may be lower, but people are able to access information and call back again if they require further support. It also offers an opportunity to people to engage in, I suppose, what we used to call brief interventions, where suggestions could be made, and if that person was keen to take up that suggestion without actually officially engaging in services, then we could arrange for a call back in a week, 2 weeks, or a month's time just to see how they were getting on. At that point, if they needed access to services, we could do that. At that point, if they managed to self-manage, then we made a difference with the brief intervention call initially. Okay, if we move on to the next slide, please. For some reason, Midlothian figures are lower than East Lothian figures, and we're not entirely sure what that is because they have a very similar demographic. But in Q1 in 2022-2023, it was 208 inquiries. That has increased to 294 inquiries in the first quarter of this year, giving a 41% increase in total inquiries to the service. So overall, we're looking at a 34% increase on year one of the full contact service year, which is very encouraging, and also means that people are getting access to services. And I think we're also getting more promotional materials out there. People are talking to other people about how to engage in services, and it seems to be continuing to grow, like I said, at a pace. Can we have the next slide, please? As you can see, for the total inquiries don't reflect the number of appointments offered. The number of appointments offered are for those engaging in treatment, so they could be with MELD or with any other sector or any other service within Mid and East Lothian. People that just want information, advice, they number quite highly, but then again, that could be a re-engagement at another time, or it could be an inquiry from another professional or statutory or third sector organisation about what's provided. Okay, can we move to the next slide, please? Laura, do you want to say anything about the triage referral outcomes as far as admin are concerned and business side?
Thanks, Bob. Can everyone hear me okay?
Yep.
Yeah.
Yeah, so as we've progressed with this service over time, we have been able to capture quite good amounts of information about where things are going, and exact numbers of engagements and the outcomes of them. So as we can see from this table, we've got from the number of appointments offered, these would be triaged to either MELD, East Lothian Substance Use Service, Mid Lothian Substance Use Service. Some will not require a referral on, that would come under NFA or other, and then your total there at the end. So we can see the proportions there. Most of our engagements going to appointment would be referrals to MELD, as you can see from that. We use a spreadsheet system to record things as they are being engaged, which really allows us effectively to record what we need to and report and present accordingly.
Can we have the, thank you. The other thing, I don't know if it's for funders, John, but the breakdown of females being able to engage in services seems to have risen as well with the advent of the contact service, whether that be through, informal questions or actually engaging in service. It proved difficult before the advent of gateways because people did not want to be seen going to gateways in some occasions. Do you want to say anything about that, John?
No, the data showing that the contact service has been successful, and we're particularly pleased with the level of engagement with by women, because we're certainly aware that particularly women who had childcare responsibilities, found it quite difficult to access service, particularly through the old gateway model, where you actually had, you had to physically get to a place. This allows women, again with childcare responsibility, far more flexibility about when they phone, how they contact, and how they may arrange further appointments. And so that balance between males and females, as I say, we're really pleased, and we think it's a much more equitable system going forward. And maybe just a final point, if you look at the data that we've just seen, unfortunately, with regards alcohol deaths in Scotland, the figures for the previous year for males were the same, but actually for females were much higher. So we think there's certainly an issue about how we engage with women and women with childcare responsibilities, and we think this is a helpful way to do it, I have to say.
Okay, thank you, John. If we can move to the next slide. Also, the age breakdown can be very significant as well. This gives us, just the way we record things, the ability to basically see what the age groups are that we engage with. It's something we've never done before, and as we expand the service and new and other areas become of heightened importance, it's also important for us to know that there's we're reaching every age group, including 70 to 79 or above. Under 20s, we tend to pass on to our services for young people, but if the person decides that they're an adult, they're working or whatever, they want to be treated as an adult, we certainly wouldn't turn them away from our service. But the demographic kind of matches everything else, that people between 20 to 49 tend to want to deal with an issue, and that's the vast majority of people that engage with us. After that, it kind of tails off, but it doesn't mean that people over 50 do not have issues with drugs or alcohol. Can we look at the next table, please? The other thing that we can do at the contact service is highlight areas where people are engaging and offer more support to that. As you can see, the vast majority of people in the Midlothian area are in the Dalkeith, Pennycook and Bonnyrigg areas. That means we can target to have our outreach appointments and outreach services go into these areas more than any other areas. Other people will be invited into Dalkeith basically to be seen, but if they're in the local area, we can at least do that. And table 9 will be exactly the same for East Lothian, which again allows us to target areas effectively and I think in a responsive manner to reflect the need of that area. Can we move to table 9, please? Okay, so we're table 8 on that. So there you go. That's a reflected area for East Lothian, with the vast majority of people coming from the Musselburgh area and outlying areas in Dunbar and Trinent. Thank you. Next table. So there we go. That's a confirmation of the number of figures that the number of inquiries we've had in the first quarter, and the increase on that is actually 520, is an increase of 34% on the first year. Just confirming that. And the next slide, please. I think it's also important to note that we always suspected that there were more people using cocaine than was actually engaging in services or combination of psychostimulants. The contact service has actually allowed us to engage these people in a different way. We've also operated a pilot about engaging stimulant users in external services, which included complementary therapies, etc. So I think we're going to be looking for funding, John, to actually expand that in the next few months, just so we can engage people. This is more of an out-hour service just now to reflect the fact that most people using substances like cocaine often work, and we need to try and catch them, meet them where they are, rather than where we'd like them to be. Can we have the next slide, please? So there's a breakdown of the contact service extension. It's in its infancy just now, but as you can see, for April, very little things going on. In May, it picked up to 2 people, and in June, the last time we did any records, it increased to 12. I think what we're noticing more than anything else is that people are very willing to engage on a Thursday and Friday. The Saturdays and Sundays are much quieter, which I don't know reflects that everybody has a weekend off, or that people just expect that there isn't any services available just now. So that's up to us to promote it more. That's up to us to actually let our colleagues in every other statutory service and third sector service know that we're available. Can I have the next slide, please? So again, just going over the initial benefits to the public, which I think I've done before. It's a 24-hour service now, but like I said, it's not manned 24 hours, and people can get engaged in treatment as soon as they require it. Next service, next slide, please. Not next service. So here's a list of agencies that benefit from us directly, taking the whole gateway process and putting it with a staff team of 3 just now, managed by Laura and I. But it certainly cuts out a lot of time and a lot of nurse hours, etc. So we refer mostly to ourselves, obviously, Midlothian Substance Use Service, East Lothian Substance Use Service, ELCA, Peer Support Service, Family Support Services, Smart Groups and Fellowships. Thank you.
Thank you very much, Bob. I've got a question, I hope you don't mind. I'm really interested in the impact of the expansion, because a lot of what we hear in the work that we're doing across different drugs programmes is just the limitations of availability and accessibility of the service. And I just wondered if you had any kind of feedback from anybody who's benefited from the expansion of that, or if you've heard from folks.
People who are working definitely, they're taking triage appointments into service on a Thursday and a Friday evening. So that can be pretty busy. We can have, well, the top rated 5 hours, and it can be stacked. Last night we had 4 out of 5 hours filled with people looking to engage in that manner. It also means there's a continuation. So workers are also given time off, say if they finish at 2:30 in the afternoon and do 2 evening appointments, then we can engage them in that way. I think the important thing is always being flexible to the needs of the people who try to access your service. And you know, they are the ones that pay our salaries, and they are the ones that we are looking to help as well.
Yeah. John, I see you've got your hand up. Do you want to come in at that point before we finish the break?
Yeah, I think the contact service is if you like, the Monday to Friday thing is well publicised, and I think we've got further work to do over how we publicise the weekend. But actually, I think there's also a public perception that they just don't assume any service is available at the weekend, and I guess it's how we change the public perception that we are moving to extend these hours, because so often they just assume, well, it's a Monday to Friday service. What's the point? What's the point of reaching out? So that change, I think we have to think to make. So.
Yeah. We certainly, within some of the data we've been looking at about people who've used acute services in hospitals, and oftentimes they self-discharge in the night, and there's some curiosity about why that is, and the availability of them to go and pick up any medicines and stuff out of hours and things. So I think it's a really interesting question about the availability of our system. And actually the demand has ended up popping up through acute services, so I'd really be interested in knowing more about that expansion and stuff. Thank you very much, colleagues. I'm thoughtful of time, so can I ask you to come back at 12:05, and that'll give you a wee 5 minutes extra break time. So I'll see you back if you just close off your camera and your microphone and catch your break, and then I'll open it back up at 12:05. Thank you very much. Okay, good afternoon, everyone. Thank you very much for those of you who've stayed on. I really appreciate that, and I know that it's a busy day on a Friday as you try and tie up for the weekend, so I appreciate you taking the time out your diary. Elise, if I can get you to open up your camera and your microphone, that would be great.
Thank you very much.
Thank you. I'm going to pass you over, guys, to Elise McConnell from the Glasgow City Mission, and she's going to give you a little bit more insight in terms of the overcoming of some of the information sharing issues that crop up in her role, and a little bit more insight in the importance of joint working. So, Elise, over to you.
Thank you very much for your introduction. You can go on to my first slide. So I manage a project for Glasgow City Mission called the Overnight Welcome Centre. We provide routes out of people for who are at risk of rough sleeping during the coldest months of the year. A lot of those individuals that come through our service are already tied in with multiple agencies within Glasgow. That is one area that Glasgow is really strengthened, is through partnership working. And so last year we saw 534 individuals come through our service. A high percentage of those guests that came through actually have what we would traditionally call complex needs, whether that be addiction, mental health issues, or those who have got no recourse to public funds. So they're already linked in with services, and then they come to us because they find themselves at their crisis moment needing a safe place to stay rather than sleeping on the streets of Glasgow. Our service that we run has been going for, we're about to enter our 14th year, and every year we have built up our partnership model of working because we realise that we're really good at what we do with welcoming people in and giving them a safe place to be, but we're not experts in various other areas. So we're not experts when it comes to addiction, we're not experts when it comes to homelessness legislation or even going through the asylum process. So we really rely on partnership working in order to get the best out of our service. So 5 years ago, we realised that the system that we were operating with wasn't a good model for sharing information with partners, again, for the benefit of our guests. So we created an online occupancy list where we checked guests into our service, and we were able to have partners access that list. They could see the guests that were using our service, and they were able to also put notes onto the guest profile. We kept it really simple because when you overcomplicate systems, people start thinking, they get stressed about it, they don't know what to put into it. And also a simple system is what works for our guests as well. So when they come in and we log them on, we only ask them 7 questions when we log them into our system. We ask the basic questions that you'll all ask: name, date of birth, nationality. We ask them for their phone number. But our most important question that we actually ask is, are you okay with us sharing your data with our partnership agencies? So at that point, we're explaining to our guests that we work with agencies across the city, and we want to be able to link the guest in with the most appropriate service. And that is why that question is so important, because if they say no, then we don't link them in with anyone. But if they say yes, it opens up this whole range of opportunity that we have in order to get the best for them. If we could go on to the next slide, please. We needed a new system because we wanted to have transparency with our partnership agencies. We used to meet once a week, but when you're dealing with up to 40 individuals at that time of night coming into our service, meeting once a week doesn't get information spread quickly to the most appropriate people. By having our partners access our site to see who is in, they were able to connect with those individuals a lot quicker in order to get the support that they needed. As the guests were already engaging with other agencies in the city, the new login system allowed us to unite as organisations within Glasgow. We were able to share that information and bring our unique expertise into areas where we could just work better together. We have over 20 agencies that we work with at the Overnight Welcome Centre, and the high majority of them actually access the system. We wanted to minimise duplication of work across the sector. You could find out a few days later that actually our guests that we thought hadn't been linked in with homeless services, the Simon community had actually already done that. And we were doing the same work. So everybody was doing the same thing. So by sharing information, we were able to minimise that and actually work a lot cleaner and a lot quicker in order to get the right support for those individuals. We created this system where we could follow a guest's journey. So on their profile, if they had said yes to data sharing, you could look through quickly to see who's that guest linked in with. Is it Shelter Scotland? Have they put a note down? Is it the Simon community? Have they seen that individual? Or is it our staff team that are putting a note up to our rehab pathways team? So a lot of our guests that come through our service, they have drug addiction or they have alcohol addiction, and when they come in their crisis moment, they're saying to us that I really need help with this, I need support, and we can just pin a note on our system to say rehab pathways team, pick this up in the morning, so that person can get that support straight away, and then hopefully we see them in the journey onto the journey for rehab. We wanted to protect the guests that were falling through the cracks. So when you saw a guest profile and there was no notes being put on it by any other agency, we could see that those guests weren't linked in anywhere. And so we were able to start that process to make sure that the guests who fall through the cracks were going to get picked up by the most appropriate service within the city. Our priority was the guests in all of this. We needed a quick way to share information and get positive outcomes. You can go on to the next slide. We faced some big challenges when creating our new online system, and that's why I'm here sharing with you guys today. GDPR, it can be an absolute headache for us all when we're working together. So that is why we asked our guests, are you okay with us sharing your data? That simple question allowed us to open up their profile to many agencies. We built into our system that if a guest said no, there was limited access for those partnership agencies. So they could see that a guest had used the service, however, they could not see their name. If they went on their profile, it said, this profile has limited access for you, so you cannot see it. And so we were very clear with our guests that they had the option to be linked in if not. And our partners, like I said, they had limited access to the system. We're also aware with GDPR that our category of individuals that we're working with do fall under the extremely vulnerable category. They're coming in because they're at risk of rough sleeping. If they're at risk of rough sleeping during the coldest months of the year, then we could see deaths on the street. We could see overdose happening, if that's what they're choosing to do out in the streets. And we needed to create this system that broke down those barriers and allowed us to get that appropriate help. So they do fall under this extremely vulnerable category because they are individuals at risk. And GDPR, if you are concerned about that individual and want them to get the help, you are able to get around that, particularly with this group of individuals. But our main question to them was, are you okay with us sharing your data? And then if there was another concern that we had and we did have to interact with somebody without the guest agreeing to that, we are aware that they are in that extremely vulnerable category and we needed to get them the right help there and then. Majority of our guests do say yes to data sharing. They are open for help, they're open for support. They just need that option to be given to them. We also had the challenge of creating this new system, and all the agencies that we work with already work with their own systems. So we broke that down by actually doing our system on a web link that all our partners have access to with a login, and it's simple and easy to use. People just put short pieces of information on. There's never anything too personal about guests on their profile. It's mainly, this guest needs to come and see me up at the Simon community for a meeting, or we had the NHS team over at Hunter Street have access to the system as well. And so they would never put anything medical on their system, but if they knew that the guest had an appointment with them, they would pin a note to that guest profile so the staff team could see that that person needed to get to their next appointment, so we could encourage them to attend that. So short inputs, simple and easy. A model that doesn't need to be overcomplicated. You can move on to the next slide. We were also aware that when creating the system that we needed to create levels of permissions on our system. So not everybody needs to see everything on people's profiles. So our overnight welcome centre staff, they had full access to the system as they're the ones that are encountering the guests when they come through the door. They could create reports. So we had a nightly report that logged anything of note that happened through the night, and they could pin the notes to the homepage and also to the guest profile. Our management here at Glasgow City Mission, we also have full access to the database. We have admin privileges that we are able to go in and merge profiles if duplication has happened. So we don't lose any information, but we can merge it all together. And we can view the reports that are created by staff. We are also able to download reports. So the database system that we operate with can pull together statistics for us. So we're able to see how many are using the service, when they're coming in, what is the breakdown of nationality, and also for recurring guests that are coming into the service. We were keen to break the cycle for those needing the service. And the majority of people that do keep coming back do have addiction problems. They're not able to sustain tenancies. They do need extra support. And so we're able to see that clearly from the system, because we don't clear the history of the guests that have accessed the service. So we do have 5 years now of information about who's been coming to the service and how many times we have seen them over the years, because those are also guests who are falling through the cracks, the fact that they're still needing the service. So we are able to see that at a quick glance as well. Our partnership agencies that used our system included Police Scotland, Simon Community, the Red Cross, Hunter Street, Shelter Scotland, and they were all able to put notes up on people's profiles who had agreed to share their data. They were able to put updates up if they had seen that guest for an appointment. And that was particularly helpful with those who are going through the asylum process, where they have appointments with their EU settlement scheme. So we were able to communicate with those agencies to make sure that that was happening, and we could see a live update of what had happened at that meeting as well. So we're not chasing up that partnership agency, but they're actively putting that information on the guest profile, which was a benefit for the guest. So the partner agencies, they couldn't see our nightly reports that we created. Those reports had a bit more personal information about what had happened if somebody had maybe had an accident on site, and we were able to keep that as our record. They could view the profiles, but they were unable to change any information on the profiles. Only overnight welcome centre staff could do that. We have a missing person section that Police Scotland really took hold of over the past few years, and they were able to input from their missing person list onto our missing person list. And so that meant if a guest came through our system, they were flagged up straight away that this person could be a missing person. And that was a really useful way of linking in with Police Scotland to make sure that we were looking out for people who potentially would use our service but might not use our service. So last year we'd managed to recover 5 people who had been reported missing, and that was because of the active use from Police Scotland on that system, and the fact that our system is simple and it recognises that 2 dates of birth could be the same people, and it flags it up straight away. As I said at the beginning of this slide, not everybody needs to see everything that you put on your system, only the important things, and the communication of meetings and what has happened and who's linked in with those guests. Those are the key pieces of information that we were encouraging partnership agencies to put onto the system. You can move on to the next slide. So we really wanted to follow the journey of our guests as they travel through the agencies within Glasgow, because as I said at the very start, we're really good at what we do with bringing people in, providing a safe place, but we are not experts in every area. So we are not experts in rehabs or asylum processes, and so we made that a priority to follow the journey and not feel like we had to be the ones to do everything. There's agencies out there that are incredible at what they do, and the short, quick notes really help that from our partnership agencies who were taking responsibility for what they were doing with that person in their area of work too. We have, when you look at the system, you can see the notes very clearly on their profile. It almost looks like a Word document where you're just looking down at everything and you see it all. Unfortunately, I couldn't show you any pictures of it today because our database is still live, so our workers are still actively using it through the year, but we're able to see very clearly what is happening with those individuals. It was successful last year with us with our rehab pathways team. So we had multiple guests end up going to rehab because the team would check the database every morning. They would see who has been asking for rehab, and then we had a number of guests actually go through that process, and we can still see in their profile that they're still in rehab, that they're doing well, and they're still being supported by the rehab pathways team. We had a 95% positive outcome rate last year for guests moving into accommodation. And when they moved into accommodation, we were able to make sure that they already had support in place as well. As I mentioned, we can see how many people have used the service multiple times. And so 88 individuals have accessed the service for 3 or more years within the time period of 2015 and 2021. So they're the guests that we will then prioritise when working with, when coming in, to make sure that we are breaking that cycle. You can move on to my final slide. So as frontline workers and dealing with individuals who are linked in with many services in the city, it's important to remember that our systems don't dictate the way that we work. We're not slaves to our systems, but actually our systems should be working towards the model that we want to go towards. So I would just encourage you that if your system doesn't let you do what you know you want to do, then I would change that so it's right for you. I'd encourage us all to think creatively again about how we work best for our guests and how we can link in with other agencies within our cities, and pushing through those GDPR rules are really important. And as I said, it's simply asking the guest, are you okay? Being really clear with them who we are linking them in with. And when we're following up with them the next day and saying we're going to be contacting the Simon community, we're always clear with our guests that that is what's happening, and the guests know that those agencies will be communicating back to us. Partnership model working is the model that currently works within Glasgow. We have seen great success with it, and we don't want to have systems that put a block to that in any way. So remember that the guest is the priority. Our systems are not slaves. We're not slaves to our system, sorry, that's what I should be saying, but they should become slaves to us. We want them to work in the way that benefits the guest as priority. I am aware that time is running short, so I'm going to finish there. And if anyone's got any questions, please put them in the chat.
Thank you very much. I actually did have a question, but I'm going to put it in the chat because I'm thoughtful of time. And I think the interesting reflection I have following your slides and just your kind of presentation is just around how important low thresholds are. So I think it's such a valid case you make about that. So if I can just ask people in the interest of time to put any questions you have for release in the chat, and we'll scoop that up as part of our event report anyway. I'm going to take the time just to sort of wind us up, if that's okay. Apologies, at least that you didn't have a chance to speak to the audience. That's often what happens. We always run out of time. We always think we have got too much and then we never have enough. Thank you very much to all of our speakers today. I really appreciate you taking the time to come to us and share your insights and share the intricate nature of your services. It's really appreciated. Thank you for all of you for joining us, hearing more from colleagues and starting to understand how you may benefit from that or be inspired by the progress that other people are making. Before you go, can I just ask you to complete the on-screen poll that should pop up on your screen at the moment, and there should be a link in the chat. If you've got any feedback or anything in addition you want to pick up with any of us, you can contact myself or Steph or any of the team. We'd be really keen to hear about that in terms of how we make best use of your time and our time for any design of any future sessions. After today, we will be in touch with you to share the slides. This is being recorded, as you know, and that will be available online through our website, and you'll be able to get it through a search engine in YouTube. If you've got anything else you want to pick up with us, we are available on Twitter, as you all know, and we use the hashtag #HisMatt. You can also email us direct at his.matt@nhs.scot. So before you shoot off, if I can just ask you to complete the poll. Thank you very much for your time today. Please enjoy your weekend, and I will see you here probably at the next one. Thank you very much.